All right. Why don't we go ahead and get started? Thank you, everyone, for joining us today for this CHEST webinar. Title of our webinar today is Navigating Vaccine Hesitancy Through Relationship Building. CHEST would like to gratefully acknowledge the following founding supporters of the First 5 Minutes program, Amgen, AstraZeneca, Fair County, Boehringer Ingelheim, Novartis, Regeneron, Sanofi, and Viatris, in addition to GSK. I'm going to let my co-speakers introduce themselves, and I'll introduce myself.
Dr. Megan Conroy. I'm an assistant professor of medicine at The Ohio State University in Columbus, Ohio, and associate program director for our Pulmonary and Critical Care Fellowship.
Hi, and I'm Susan Corbridge. I'm the Chief Essentials Program Officer at the American Association of Colleges of Nursing. I'm Professor Emerita at University of Illinois, Chicago, where I worked with pulmonary medicine and as a nurse practitioner for over 25 years and was on faculty in the College of Nursing.
And I'm Ryan Mabes. I'm an infectious disease and critical care physician and professor of medicine and anesthesiology in the sections of ID and critical care at the Wake Forest University School of Medicine in Winston-Salem, North Carolina. So let's go ahead and get started with kind of phrasing this question. What challenges do you face in building trust of patients who are vaccine hesitant? So I'm going to start by giving kind of an overview of vaccine hesitancy, but also an overview of just the key things that vaccines have brought to society and brought to public health to try to frame then later on the discussions that my colleagues will provide on how we can address these challenges of vaccine hesitancy. And again, I'm Ryan Mabes. These are my disclaimers. So let's start at the beginning of vaccination. The beginning is with Edward Jenner and the initial inoculation of people with cowpox, a closely related virus to smallpox. And that in turn led to the development of what is now vaccination, and the first true vaccine being the smallpox vaccine. So smallpox is a large double-stranded DNA virus. It is highly contagious. It was the first true vaccine in 1796. It's actually where the word vaccine comes from vaccinia, which relates to cowpox. This is the only human infection to be successfully eradicated. And to think about the scope of that, there were 15 million cases per year up until 1967 of smallpox. In the 20th century, there were 300 million deaths due to smallpox. And it is because of vaccination that disease is now a disease of the past. These are the last three victims of smallpox. Rahima Banu Begum, who was a child who was the last known person with naturally occurring variola major in Bangladesh in 1975. Ali Maleen, who was the last known person with naturally occurring smallpox of any kind in Somalia in 1977. He went on to a long career as a public health advocate and sadly passed away in 2013 due to malaria. And then Janet Parker, who's a medical photographer in the United Kingdom, who's the last known person to die of smallpox, in her case due to a laboratory accident in 1978. So if we look at the impact of infectious disease mortality over the course of the 20th century, we see a steady decline with that obvious spike there due to the 1918 Spanish influenza pandemic. And we see punctuate along here vaccination, the Salk vaccine, the Vaccine Assistance Act, all playing a role in this gradual decline. If we compare that United States data with the entire world, we see the very top of this curve here shows infectious disease mortality up until 2019. And that highest rate that we see there is largely in sub-Saharan Africa, whereas the United States is way down there at the bottom, in that green line. Well, this is up to 2019, though. So we all know what happened in 2020, where both globally and in the United States, infectious disease mortality spiked up dramatically and rapidly as a result of the COVID-19 pandemic. When we look at the overall burden of respiratory tract infections globally, the most common etiology is going to be pneumococcus. There are 344 million cases of predominantly pneumonia per year, and this is in 2021. And this is non-COVID pneumonia, by the way. If you look at the mortality rate, there were over 2 million deaths in 2021 due to non-COVID lower respiratory tract infections. Now, we've made a lot of progress in just a 30-year period, with a 75% reduction in pneumonia mortality in children under 5 and an almost 25% reduction in adults over 70. And a big part of that has been the introduction of improved, or in many cases, new vaccines to Streptococcus pneumoniae, for influenza, very recently for RSV, and of course for COVID-19. Unfortunately, the situation we find ourselves in now is we're seeing a reemergence of vaccine-preventable disease. So taking the example of measles, you need what we call herd immunity, which means that there is enough immunity in a population to prevent widespread transmission. You need 93 to 95% vaccination rates to prevent measles transmission within the community. And measles is jaw-droppingly contagious, with attack rates in the 90 percentile for people who are non-immune, who are exposed to another person with measles. So unfortunately, many U.S. states and territories fall far short of this 93 to 95% required vaccination rate. Why is this? Well, on one hand, you have challenges with access to medical care. On the other hand, you have issues of mistrust of medical care. It is interesting to see which states have the highest rates of pediatric vaccination. Just again, using the measles, mumps, rubella vaccine as a prototype here. And it's not always where you'd expect. Mississippi, for example, has a very, very high kindergarten vaccination rate, as does much of the Northeast. My home state of Washington State is sadly a little bit on the low side. California kind of came from behind and really recaptured its place on this ranking board as a result of some legal changes a few years ago. Part of the challenge is non-medical exemptions for school immunization requirements. So 30 states and the District of Columbia allow for religious exemptions for childhood vaccinations before starting school. 13 states allow personal or religious exemptions, personal meaning a personal belief exemption. 2 states allow for any personal exemptions for any reasons. Again, interestingly, Minnesota is one of them. And then 5 states don't allow for any non-medical exemptions at all. And those states tend to have some of the highest rates. Again, California, West Virginia, Maine, New York, and others. So, there is this widespread in how public health is done in the United States, with a great deal of it done at the state level. Often that is for the good, but there are some net negative benefits on occasion. The net effect of all of this is only about 2/3 of U.S. children have received all recommended vaccines, and that meaning all recommended vaccines from ACIP and the CDC, despite the fact that generally well above 90% have received at least MMR to start school. Well, how about adults? I don't take care of children myself in my practice. Fewer than 50% of U.S. adults have received all recommended vaccines for their age group. And in general, only slightly more than half of U.S. adults received annual influenza vaccinations, and that's pretty consistent year to year. A little bit of a small uptick in the setting of the COVID-19 pandemic, but still generally less than half. What if you look at, by states, who does more, who does less? Higher performing states, so to speak, such as, again, Minnesota and Washington, tend to do better than states with lower vaccination rates, like Florida or Alabama, but these are all pretty mediocre. And this is really nothing that anyone should be too proud of. So going back to measles for a moment. So there in 2019, due to declines in global vaccination rates, we've seen periodic and relatively large outbreaks of measles. In the United States in 2020, there were 1,275 cases of measles, which was at that time a record-setting number. But when you adjust this for population, we actually didn't do as bad as some of our peer nations did. The United Kingdom had 1,000 cases despite having a much lower population. France, 2,600. Russia, 4,500. Brazil, nearly 21,000. Ukraine, prior to the war with Russia, 57,000. And the Democratic Republic of Congo actually had 330,000 cases of measles. In the year prior to that, there were 140,000 measles deaths worldwide. We tend to think of measles as a disease of the past here in the United States, but 140,000 global deaths due to a disease that is entirely vaccine preventable. There's a brief lull. Measles cases declined. 2022, again, a series of relatively large outbreaks. 2,300 cases in the European Union, predominantly in Romania and Austria. 41,000 cases in India in 2022. So we still have a lot of work to go before we get anywhere close to true measles eradication. Now, why does this matter, right? I mean, I think a lot of us certainly, I am not as young as I used to be, but I am young enough that I've never really seen more than a handful of cases of measles in my career, and none in the United States myself. Well, it turns out that measles has some unique immunologic effects. And one of the effects of measles is it wipes out memory B cells. So essentially resets the immune system of a child or an adult who's been infected with measles and leaves them more susceptible to subsequent infections. And so the net effect of this is that measles vaccination reduces all-cause childhood infectious mortality. And you see this in England and Wales and in the United States, both of whom introduced universal childhood measles vaccination in the 1960s. Now, you look at those curves and say, okay, those curves were going down before measles vaccination, and they continue to go down afterwards. But now Denmark didn't introduce universal measles vaccination until the 1980s, until the late 1980s, in fact. And there you see the same phenomenon. Shortly after the introduction of measles vaccination, all-cause childhood infectious mortality declines. So measles is special, and it's special for a reason that it has these secondary immunologic effects that reduce all mortality. Well, what about pneumococcal disease? So this is a Pulmonary and Critical Care Society. So when you look at kids less than 5, you see a big drop off in 2000 with the introduction of the conjugate pneumococcal vaccine, a big drop-off in trends in invasive pneumococcal disease. Then you see a somewhat smaller drop-off in 2010 when the 7-valent vaccine is replaced with the 13-valent vaccine. What's interesting about vaccination is vaccination ideally prevents disease not only in the individual who receives the vaccine, but also prevents it in others to whom they're exposed. And pneumococcal disease is a great example of this, because when you look at trends in invasive pneumococcal disease among older adults, so those of us 65 years and older, you see a similar drop-off in invasive pneumococcal disease in older adults when the pediatric vaccine is introduced. And the actual reductions due to adult vaccination are relatively smaller. So vaccinating kids protects kids, but it also protects their grandparents. And that is a great example of the kinds of things that we can accomplish with a good vaccine campaign. So how do we increase these vaccine rates? Well, just a few principles. So vaccines don't work when they're still in the vial, right? We have to get them into people. Vaccine hesitancy is complex and it takes many forms. Vaccine resistance and hesitancy during the COVID-19 pandemic, the kinds we saw in the news, the kinds we heard about, and maybe saw in our clinic, is not the only form of vaccine hesitancy, and it's not the only challenge we have in addressing low vaccine rates. At the same time, we have to address equity along with hesitancy. That people don't get vaccinated not just because they don't want to, but because they don't have access to care. Looking at challenges with primary care access in the U.S. and then global vaccine availability, particularly in low and middle income countries. So this is in my state of North Carolina, where I live and practice. This was a survey done by UNC in 2021. And what they identified was that COVID-19 vaccine hesitancy rates were higher in younger adults. It was actually relatively rare in those 65 years and older. And we see that in vaccine rates for older adults. It was more common in men, more common in those with lower educational attainment. And interestingly, it was more common in households with children in it. That may be a bit of a confounder. Nonetheless, this was not a thing that had a political spin to it. There were high rates common in all racial and ethnic groups, and in fact was highest in Black and Hispanic and Latino residents of our state. Well, how about another state? Why don't we go up to Minnesota? This was done by Dr. Jamie Felser, who trained at Mayo and is currently faculty at Emory. And what this study showed was that there were, again, relatively high rates of vaccine hesitancy among Hispanic and Latino residents of the state, as well as Black residents of the state of Minnesota, that it was relatively more common to see vaccine hesitancy in unmarried people, and that vaccine hesitancy became less common with higher rates of educational attainment. So what does it come down to? What can we do about it? I am I don't work for the CDC. I don't have any official role in terms of setting vaccine policy, but I am a practicing physician. And what is reassuring and gives us a path forward, and my colleagues are going to talk about this in greater detail, is who do people trust? Well, it comes right down to it. People trust their doctors, their nurse practitioners, their physician assistants, the clinicians who are responsible for their care. They trust us. And we can use this relationship to try to build the bridges with our patients to get them more willing to accept vaccines, both for their own health and for the health of their communities. We're going through a lot of challenges right now in our country and in other countries. Challenges with increasing, shall we say, what's a good way to put this? An increasingly verbal movement that is opposed to vaccination. And I would just say, although this can seem like a grim time in a lot of ways, this is not new. We have gone through this before as a country and as a society, and we will go through it again. We got through it last time, and we'll get through it this time. That's all I have to say about this. I'm now going to turn over to Dr. Corbridge, who's going to talk us about the core tenets of this first 5 minutes concept that we'll be using to help address vaccine hesitancy in the clinic.
So thank you so much, Ryan, for all that great information. Again, I'm Susan Corbridge. Can everyone see my slides okay? Great. Okay. I'm Susan Corbridge, and I am excited to talk about the first 5 minutes today and to talk about the tenets of the first 5 minutes. My only disclosure, my husband is employed by GlaxoSmithKline Pharmaceuticals, and I have nothing else to disclose. So the first 5 minutes is really an evidence-based approach to help us as healthcare providers really increase our communication skill set and increase trust and build patient rapport in those first very critical minutes that we see patients. And it uses evidence-based skills. And I, really am a firm believer in this program. Chess put this together a few years ago, and I was able to be on the steering committee and had a great time with it. And, as a nurse practitioner, it's the first thing that we learn in nursing school is communication. And I really have always prided myself on being able to build a great rapport with my patients. But I do have to say the first 5 minutes program and being involved in it has really increased my overall efficacy and just efficiency in clinic as well. And it's really provided a great foundation for me. So I want to talk a little bit about the core tenets of the first 5 minutes. One thing Ryan mentioned was that patients who are vaccine hesitant, there's almost always some mistrust. And one of the things, as he points out, is our role as healthcare providers is really to help patients be able to trust the healthcare system and to also make sure that we have addressed any misinformation as well. And when patients trust their providers, that also helps them improve their outcomes because we know that there's an adherence to treatment as well. I mentioned a little bit about improving quality and efficiency of your practice. And one of the things we'll talk about, one of the core tenets of the first 5 minutes is that it can help do that. Here's another piece that's really important with the first 5 minutes. Again, an evidence-based approach to this to really increase our skill set around communication. It also helps connect with patients from diverse backgrounds. I have always worked on the west side of Chicago in a very underserved population in a pulmonary clinic there. And it's really been, just very important for me to be able to connect with my patients who most of them are from very different backgrounds than my own. So it's a very important way that we can really connect with our patients. One of the other pieces about increasing your skill set and communication skill set and building that trust and rapport is that we know that it enhances our work enjoyment as well. There are data to support that. And I'll talk a little bit more about that too. So Chess did a listening tour during COVID in 6 regions of the country that really were experiencing disproportionate morbidity and mortality. And one of the things, the biggest thing they found was there was a mistrust of healthcare providers. It really showed that there was dismissive attitudes among physicians and lack of understanding and or appreciation about the social determinants of health, which Ryan really led into that about some of the issues, again, with vaccine hesitancy. So that's why, it's really important that we're moving in this direction to increase our skill set and build patient rapport. They also found that there was an overuse of highly technical and medical terminology and also potential implicit biases that really, prevented optimal patient outcomes because, again, it was an issue with the patient-provider communication and rapport. So we know that an empathetic listening drives better outcomes. Here, there are, again, evidence supports that when you have are an empathetic listener as a healthcare provider and you can build trust and you use this approach and really have trust and patient rapport, that we know that we have increased patient outcomes in all these areas. And you can see some of the particular references there that support in pulmonary, in particular with COPD and lung cancer patients. And I think one of the big things that's not on that list about patients that's so important, that we know that it also, when you have empathetic listening and patients trust their healthcare provider, that there is reduced anxiety and stress. And we know that fear and around any illness or any healthcare issues and miscommunication that have to do with health can really take a huge emotional toll on patients that impacts their overall emotional health and well-being in general. So, it really can, having a great relationship and building trust can also definitely reduce anxiety and stress, and there are data to support that. The other piece, too, that we know that having a great relationship and building rapport with our patients can actually also lead to empowering patients to make really be active supporters and active engagement in the decisions that they make about their health care. That's really important because then they can make decisions that really are aligned with their values and their principles as well. So really important for patients. Obviously, I think all of us with our own healthcare providers, we really want to be sure that we are heard and we can trust our providers. The other piece, too, is that for all of us as healthcare providers, when we do have empathetic listening and good communication skills, and we really approach this in that regard and with intentionality, that it's much more fun. We are engaged. We get to know a bit about our patients more on a personal level. It decreases workload stress. I think that's one of the biggest pieces when you look at the evidence about that. With the high rates of burnout in healthcare providers, it's very important. Anything that we can do to decrease stress is key. It increases team collaboration, and we know that's really important in a professional team-based approach to care. And in addition, one of the biggest pieces that empathetic listening and trust in providers actually also decreases medical malpractice litigation. So that's an important piece to note. And then from the institution side, there are many reasons that institutions really should support healthcare providers being educated appropriately to really focus and intentionally on increasing that rapport with patients, because it does a lot on the institution side as well. So Chess put together some really great first 5 minutes information. And again, it was really fun for me to be part of that several years ago. And I'd like to, just make you aware of this. It's something that there are e-learning modules on the Chess site. They're all free. There's also a really great virtual reality skills practice. You can either do it with a headset or online. But again, it's just a great way to really, again, focus on our communication skills. It's great for students as well. I think, we've kind of connected with a lot of the nurse practitioner programs because I really feel that the nurse practitioner students should be focusing on this as well. And in addition, I think any students that come through, but all of us, even, like I mentioned in my own clinical practice, it really it is a great program. The other piece of the first 5 minutes, and Ryan touched a little bit as well with the social determinants of health and really connecting with our patients. But the first 5 minutes program also recently launched a bit into cultural humility modules. So I'd like you to take a look at that too. And then we also just did one on compassionate COPD care. And then again, now we're diving into a little bit with vaccine hesitancy. So that's really fun. So I want to just turn your attention here, and I would invite you to download the skills card for first 5 minutes. Again, this is an evidence-based approach to really foster rapport and trust with our patients. And the first part is really pausing to reflect on our own implicit bias. And I think, that piece is key. I know many times when you're running from patient to patient and you're busy, that's a piece that often gets missed. So I think, it's really important that we stop and focus focus on that. And again, the evidence bend walks us through how do we create rapport, it provides some tips. I'm going to walk through this in a little bit, eliciting a list of concerns and of the patient when they come in, and then negotiating that agenda. And then going into opening the conversation and exploring the personal story and really naming the emotion, which if you look at the back of the card, that's those Pearl statements. Really look at the back of the card and how we respond to patients. So all these things, this is again an evidence-based approach that really helps build trust and rapport with our patients. So again, the first part, pausing to reflect on implicit bias, creating rapport. Quickly, I'm going to walk through a little bit of this, elicit all of the items, negotiate the agenda, and then opening that conversation and exploring their personal story. So again, all evidence-based to help us build trust. So I think the first thing, if you stop and think about a time, and I think, this happens probably more often than not to many of us. And a lot of it is because we're busy. We all have implicit bias that we really need to make sure we are focusing on and paying attention to. So I just, would ask you to recall a time when your implicit bias may have influenced approach before even meeting with your patient. So, it's the first piece of building trust to really stop and focus and reframe those assumptions with curious questions. And it's really something that I think if we focus on, and the program really tells us to, let's just really stop and focus on this and make it a part of your practice when you see every patient. And that's really a great way to start. And then in beginning the interview, again, these are small things that really are big things to help build trust with your patients that have been shown that really work. Greeting your patient and whoever is with them, making sure that, you do the small talk before the big talk. And also if you're in a clinic, I know we have a clinic with lots of different healthcare providers and clinicians, but explaining your role and who you are so that they know. It's hard for them, and especially in big practices, to really know who everybody is. So I think that's an important piece. And then a little bit of small talk goes a long way. People want to be seen and heard, and remembering small details about people or asking something personal about them or just making a little bit of small talk really helps people feel seen and heard, and it goes a long way. And then also clarifying expectations for time and interruptions. If you feel that you're going to be called out, you're waiting for another call for maybe on another patient, it's important to stay. I'm waiting for another call and I may have to step out for a minute, but I'll be right back in. Your time is important to me. Instead of just getting up and leaving. Again, these steps they seem small, but they really go a long way in building trust and patient rapport. And then addressing any communication barriers. So I didn't, in lieu of time, there's a great video that they're going to pop into the chat if you get a chance to take a look at it. It's part of our initial first 5 minutes, the initial first 5 minutes modules. But taking a list or taking a look at this, I think, is really helpful to focus on what are the missed opportunities. And I'd like to also point out, when you do watch it, it's a very short clip. It's not even a minute long, but when you do watch it, there's some positive things he does. He comes into makes eye contact. He comes in really energetic. Those things go a long way with in creating trust with patients in that initial encounter. But you'll see when you watch this, he kind of jumps right into the patient's symptoms, and there's a missed opportunity to connect at a deeper layer. So I would encourage you just to kind of take a look at that. And something that we can all pay attention to. But again, in a busy clinic, I know it's difficult, but we can all pay attention to, because those small things are what really go a long way in building trust. And the next piece then is eliciting all concerns from patients. And I think when when I first was told, when we were doing the first 5 minutes of evidence-based approach, and when I first heard that, I thought, oh my gosh, I'm going to be there for hours. My patients will just keep talking. But the data do show that if you elicit all concerns from your patients, say, I'd like to get a list of everything that you want to go over today. And the data do show that they will say 3 or 4 things, and that's about it. It also shows that the data support that patients usually state their main concern last. And so that saves that, and I put this in here about the hesitations. Again, like my hesitations are, it And I think most people, we think we're going to be there for a long time, but the data do not show that, do not support that. And since I've done this in my own clinical practice, that hasn't been the case either. So I think that's important. So when you do that, and by asking, I'd like to get a list of all your concerns today, it saves you that doorknob question, which is that question you get when you think you're done and you have your hand on the doorknob and they say, wait a minute, I want to talk about X, Y, or Z, and it's something really important that you have to go back in and start all over. So if you get that list of concerns, and it's often something big, remember they typically, patients will typically save the most important topic for the end often. So that helps you and will increase your efficiency overall. Then it's important to negotiate the agenda. So you know what their priorities are, but then you have to state your clinical goals as well, and then negotiate a plan. So you might not be able to go through all of their priorities. If, for instance, they tell you my biggest concern is my cough, but I also have back pain, and you're not going to be addressing the back pain. So you could say, I know these are your concerns. Today, I'd like to address the cough. I also want to go over your medications. And I know you have some back pain, but I'm going to ask you to talk to your primary care provider about that, since I'm here as your lung nurse practitioner. So I think it's important that, we really are able to cover that so the patients, again, feel heard. This goes a long way with building trust. And then stating our clinical goals, covering the medications, going over the pulmonary function test, and then negotiating a plan for that visit is key. So here again is the list that comes from the skills card, and it's really an important evidence-based approach to acknowledge and start building patients' trust. And I think, again, this goes a long way as we continue to work with patients who might have vaccine hesitancy. I'm going to walk through, again, I showed you that card there. And the biggest piece when you respond to patients as well is to use what we call pearls. This is on the back of the card that you'll see, but it's really responding to patients with these statements, letting them know that they are heard. And that's really also goes a long way with building patient trust. This is, again, all evidence-based and supported with that. And with that, those are the core tenets of the first 5 minutes. And I'm now going to be turning over to my colleague, Dr. Conroy.
Thank you, Dr. Burbridge. I believe you all can see my slides here. And with those really sort of great overviews of some of the science in vaccination, the efficacy that they can provide us, and what I've often framed to myself as kind of back to the basics, back to the foundational aspects of communication as a physician with our patients, I will strive to build on that some. I have no disclosures, no financial disclosures to provide you. One disclosure that I'm also faculty with an organization called Vital Talk, and I will use communication techniques that are inspired by Nat teaching philosophy. So thinking about some tools that we may have to bring us beyond those first 5 minutes, beyond the beginning of that visit, even beyond perhaps the beginning visits with the patient and longitudinal relationships, to think about how we can tackle some of this tricky work in navigating discussions with patients who may be hesitant to take vaccines. First, I will ask you to kind of acknowledge and perhaps even name your own emotion in thinking about this. I know I personally have struggled at times, since 2020 in particular, with compassion fatigue on this topic. As I sort of experienced secondary trauma of caring for the critically ill patients in the ICU due to COVID, sometimes these conversations took a lot more emotional energy from me than others. And I'll submit to you that if this is something you can identify with now or in the past or in the future, that using and learning some of these communication techniques, also as Susan had mentioned, there is data that as we work on our communication techniques, this work can help to improve burnout and build more resiliency. We also know that how our own emotional state is doing impacts how we communicate with our patients. As Dr. Maves told us, patients have varied reasons for why they may be hesitant to accept vaccination. And there's a lot of different demographic diversity as to who might be hesitant. Looking at some studies, common responses for why people might be hesitant to accept vaccines are things like general distrust in governmental agencies that are tasked with assuring safety and efficacy of vaccines, They may find frustration in politicization or media hype of vaccination, or feel worried about side effects. Or it may also be the well-founded and compounded mistrust resulting from historical abuses from the medical system against Black persons or persons of color. Whatever the reason, for any one person, these reasons are going to be highly individualized and really personalized contextual reasons that are fueling their hesitancy. And so I'll pause here for a second. I want you just for a moment to reflect in anything that I said there, if I triggered any big emotional response for you. In hearing about mistrust in government-funded vaccination development or politicization of medical advice, does this trigger a response for you? And what is it, if anything? Could it perhaps be any of these emotions that I have listed on the screen here? Something similar to them? Or I don't know if any of you identify positive emotional responses to that, and perhaps. And if so, that's great, because I bet if you're feeling somewhere within these positive emotions, hopeful, resourceful, creative, and wise, you can approach more difficult tasks with greater ease. Compared to if you're feeling worried or defensive or judgmental, particularly if you're feeling judgmental towards your patient, you're not going to engage with them as effectively. So what to do? How can you move yourself from feeling judgmental or defensive in a moment to feeling more hopeful and resourceful? This is not an easy task, and it's literally not easy in the middle of a clinic appointment with 10 agenda items to get to. So rather than suggesting that you should or even really can just move yourself easily from one space to another, I instead ask, if your initial response is in these red, if you feel defensive, can you more easily get yourself to a curious state of mind? This isn't as huge of a leap, just moving yourself into a state of curiosity. We heard from Dr. Corbridge that framed for us this tool to help mitigate our implicit biases with patients is to really reframe our assumptions with curious questions. So curiosity in this space is your friend. It is helpful. And I'll submit to you that patients who aren't sure if they want to accept vaccines are not one size fits all. And if giving the clear scientific argument for how well vaccines work was sufficient to enact uptake, then we wouldn't be here today talking about this. So now, by the time you graduate medical school, you are capable of really knowing the medical details on vaccines. But what you need to learn in the room, and what we all need to practice, and we all have opportunity to improve on, is really to find and elicit from the patient what their perspective is, and then find a way to partner this towards our shared goals for their health. So if you can come in and approach these conversations about vaccines, starting with curiosity, using evidence-based communication techniques, you can more easily build trust and personalize your counseling to reach the patients where they're at. Really using curiosity as a starting point can help you to respond to the patient's beliefs and concerns with more empathy. Importantly, before you venture into the space of counseling a potentially hesitant patient, you'll need to start with obtaining permission to move into this topic. Now, we know that there are some patients who have made up their minds about vaccines. They will not accept them, or they will. And these are not the hesitant patients. These are the decided patients. The patients who are unsure are the ones that we have the opportunity to connect with. And this is really sort of important definition of our audience to start with. So if we have negotiated an effective agenda with the patient, as Dr. Corbridge had noted in the sort of foundational first steps in first 5 minutes, it may be that we are the ones who want to bring up vaccinations with our patients. For me, among my vaccine hesitant patients, it's usually my experience that it's on my agenda and not on theirs. And just like we teach you sort of how to take a history in medical school, and I'll remind you that we say to start with open-ended questions, the same applies here. And so starting with open-ended questions and asking permission will allow us to invite more engagement with a possibly controversial topic. So here's an example of sort of beginning conversations, asking to my patient, I wonder if we can talk about some ways that I can help to prevent your COPD from flaring. And they say, what do you mean? Well, let's talk about some vaccines. And if the patient says, I just don't know if I can trust them, the first skill that I will submit to you is a very simple script. Tell me more. Tell me more. If you're not sure what to say, if you're trying to find yourself way back into that state of curiosity, tell me more is a powerful phrase. Because really, what you need is more data points from your patients. You need more data points of their perspective. And the more that you can understand them, the more data that you have, the more you can understand how to approach the individual in front of you. So then what? Patient gives you their perspective, and there may be any of many reasons that we've already prior talked about that they offer, or something entirely different. Your next step to continue empathic relationship building with the patient is to consider ways to acknowledge their concerns without judgment. Acknowledge their concerns without judgment. Thanks for sharing with me. I've heard other people bring these concerns up too, and I can understand where you're coming from with that concern. That may even still be misinformation that they have, but by acknowledging it without judgment, as you work to correct that misinformation, invites an open space where the patient will feel more likely to share their concerns with you. The First 5 Minutes program uses the acronym PEARLS as a way of giving you some examples of some naming statements, some simple statements that when you're not sure how to respond to these patients, but you need to continue that conversation going, continue the engagement with that patient to be able to get more data points from them, to understand their perspective. Here are some examples, just from my perspective, in those PEARLS. In making partnership, naming an emotion, showing appreciation for them, giving respect to the things that they're doing to help with their health, and understanding that vaccination might be one next step, giving legitimization to the fact that they are feeling concerned about these things, and then always partnering to support that patient. And so using some of these communication techniques really can help to deepen that connection with your patient. Now, what I'll say is before you can really proceed into medical reasoning or making the recommendation for a vaccination, you really, again, need to have more data points to hopefully be able to have enough to be able to align your recommendations for your medical care, such as vaccination, with the patient's goals for their medical care. The thing is, you've already learned these skills. We've called it motivational interviewing, and you use it probably, for those of you in the adult world, or even pediatrics, to do tobacco cessation counseling. You ask the patient to identify themselves. What are their barriers to quitting smoking? And then you help coach the patient through identifying things that they identify that they can do to overcome those barriers. And so you really guide the patient through that. And what can be very helpful to get more information from this patient are asking questions like, what worries you most? What are your goals with regards to your breathing? These are still pretty open-ended, but help you get a better perspective on that patient. Once you have these goals, it is very helpful then to use the patient's own words, the patient's own priority, the patient's own goals to then be able to link your recommendation for vaccination to what it is that they want to accomplish. Again, this is core tenets of motivational interviewing, things you're already doing, but reframing it of how you can use it in the vaccination space. So taking this open-ended step just one step further, after you've obtained information about the patient's goals and worries, again, asking permission if you can share information. Things like, can I tell you what I know about the vaccine efficacy? Can I tell you how I think about side effects with vaccines? Or in my own experience, as I had my own son in the youngest age group of a randomized controlled trial for a vaccination early on in the pandemic, why I recommend these vaccines for all of my patients and my own family. I'll share a short story with you. I practice in Columbus, Ohio, and in my pulmonary clinic, I have a pretty wide geographic catchment area. Recently in clinic, I had a patient follow up for some routine vaccine care, and he has a history of frequent hospital admissions in the last year to a more rural hospital for his COPD. He's an individual with a lower health literacy, and we talked about vaccines about a year ago when I last seen him, and he really gave me no daylight between us to talk about this. And so I recognized at that time I had come in, and it was just kind of on my list on the many things in a first patient appointment that I wanted to do, and said, here's all the things we got to talk about. And I just started with recommending the vaccine. I didn't take this time to take a more open-ended role and talk about his goals. And so I had a little bit more time in clinic this time, and I knew him a little bit better. And so I asked him, what is your primary goal? What are you hoping to get out of treatment for your COPD? And he shared with me that the most important thing for him was just stay out of the hospital. And I said, well, I actually have some therapies that we can talk about that can help you to stay out of the hospital because of your COPD. I explained that infectious triggers are some of the most common for COPD flares, and asked permission to then talk about ways to prevent them. And as I approached his rationale that he'd prior given me to say, I don't want vaccines, with more curiosity and got more information from him, he shared with me, oh, I took that pneumonia vaccine. That one, I got that a couple years ago because my doctor said it was just one time. And I learned from him that his skepticism actually came out of vaccine schedules, and that he had some skepticism about booster schedule for vaccine, and that ones that are annual, he had more hesitation too. But he was really open to taking vaccines that might be one-time vaccines, which gave enough that I could partner with his goals to stay out of the hospital. I could partner with his current beliefs and worries about vaccines for one-time vaccination, and was able to recommend and partner with him to recommend the RSV vaccination, which he accepted and then went home and got. And so this also requires some follow-up. I'm not telling you a story where my vaccine hesitant patient accepted every vaccine I recommend for them, but to set some follow-up. And I asked him his permission. I said, would it be okay with you next time you come back if we continue to talk about vaccines that I recommend to help keep you out of the hospital for your COPD? And in asking that permission, he agreed to sort of contract that we in our ongoing relationship can continue to discuss these things. I will sometimes say to my patients, my promise to you is that I want to make sure that I am giving you the best recommendations for your health, tailored to the things that are most important to you. And so if it's okay with you, I'd like to consider continuing to explore this in the future. So sometimes it's not all accomplished in one conversation, but really you can lay the groundwork and get to the future. So as we mentioned, there is a Q&A function in the chat that you can utilize here for our final closing time. What's challenged you the most? What is it that you are struggling with? Are there ways that we, through discussion together here, might be able to address some of these? I hope that I have convinced you that really by coming in with curiosity, you can connect to your patient's goals, and that listening in empathic ways and responding with non-judgmental words back to your patient, and also asking permission before entering controversial topics can help to build relationships that may help to bridge gaps that we may be struggling with for vaccines. And with that, would like to remind that this activity was sponsored by an educational grant from Moderna. And there are lastly some references.
We have a few minutes left. I don't see anything in the Q&A right now. Dr. Cloner, I was struck by your story. I had a very similar story pre-pandemic with when I was still doing a fair bit of HIV clinic with a gentleman I took care of for many years, and and over the course of a decade, kind of sort of gradually, as we got to know each other better, to sort of chipping away until actually by the time that the pandemic hit, he was very enthusiastic about receiving the COVID vaccine. So yeah, that definitely resonated. That was a great example. Thank you.
Yeah. I think something that struck me too is, in those relationships, and we talk about this sort of navigating vaccine hesitancy by relationship building. I shared with you, the personal story on my own, and I was sharing with my patients that I had my son in a randomized trial for a emerging COVID vaccine. And for some of most vaccine hesitant patients in the pandemic, discussing with them, they had known me when I was pregnant, and then they saw me after I came back from maternity leave, and sharing with them, these are the people who were like, show me pictures of your son. I want to see the baby. How are they doing? The small talk that we had, they would follow those things up. And taking the opportunity in that relationship and making the personal choice to share some of those details with them really did actually have a pretty profound effect on some of my patients. And so I think it really helped them to understand that I'm there to partner with them. And some who had maybe mistrust in doctors in general kind of learned to understand where I'm coming from.
I actually also really found that especially in the earlier days of the pandemic, to share a personal story with them, because my patients that I had taken care of for many years, were still vaccine hesitant, particularly with the COVID vaccine. And so they wanted to know what I chose to do. And I had chosen to be one of the first ones to get it with our group. And so that does help with them. And I had several say to me, it really helps that you share your decision and your journey. And I think that's an important piece too with that. I love how you talked about, again, I think it kind of dovetailed on with the first 5-minute tenets about, the exploring things with curiosity, because then you can actually know why is it, and again, what their perspective is. I think we've got a question.
Yeah. Sheila's put in the chat, I often see posts on social media that discuss vaccines and people post affirmation of vaccine avoidance. I feel like I want to chime in and encourage people to consider them. I know this isn't really a relationship question, but it seems like a chance to get information out instead of disinformation.
Absolutely. It is I have mixed feelings about the role of social media in these things. I think that, on some level, we've given a megaphone to people whose opinions may be, shall we say, difficult to support, right? And we create echo chambers where like-minded folks can amplify one another's beliefs, and that's not true just of people opposed to vaccinations, but it's also true for us, right? We talk to each other. We reinforce each other. I suspect that Dr. Conroy and Dr. Corbridge and I generally agree about most of this. I do think that it is useful to chime in and encourage people to consider them when you have those opportunities. I think it has to perhaps to be more successful, way more likely to be in your own circle, right? Your friends, your family are more likely to, my family members who may have a different worldview than me are more likely to listen to me as me. And they are some, rando ID doctor dropping out of the sky to post something on Facebook. You may have more of an impact there. I don't know. What do you folks think?
I think actually trying to, because that's how misinformation can get just cycled, and then people don't go back. We're always taught as healthcare providers, right, to go to the primary source. But typically what's happening in social media can escalate misinformation as well. So I think, even gently providing people to a valid and reliable source of information, I think is key. So it might be one way to do that as well.
And the thing frustrates me in social media is those interactions often lack that back and forth, that ability to really kind of get their perspective and be able to respond to that in a way that continues the conversation and that deepens that connection.
Yeah. That interesting comment about some are people seeking doctors that don't force vaccinations. My outpatient practice is mostly transplant infectious disease, right? So it's people who are looking to get a new kidney, a new heart, what have you. And our programs do require, is perhaps not the word, but do expect that patients receive certain core vaccinations. And that's because, particularly in the case of kidney transplants, we don't want to increase the mortality. A very large number of kidney transplant recipients died during the pandemic, and transplanting someone for a life-prolonging procedure like kidney transplantation rather than a life-saving procedure like heart transplantation or lung transplantation, may, during times of high disease transmission, in fact, increase their mortality. And that was a discussion we had with folks. And I told them in the end, listen, I'm going to give you the best advice I can. I'm not your mom or your dad. I'm not a cop. I'm not a priest. I'm not going to follow you home and make you do what I think but this is what I think you ought to do, right? And I tell people, I'm not going to force you, but you need to take this into account when you decide to accept the gift of transplantation. And I think most people listen, but it takes time. Just like you're saying, it's not always a one-time visit. It's often a multiple visit kind of thing. Well, if there aren't any other questions, shall we adjourn?
Sure.
All right. Well, thank you everyone for joining us today, and thank you to Chest for sponsoring, and Moderna for the opportunity to give this talk. And we'll look forward to hearing from you all again in the future. You take care.
Thanks so much.
Bye.